Hello, and thank you for joining today's program on neuropathy myths versus facts presented by the Foundation for Peripheral Neuropathy. In honor of Peripheral Neuropathy Awareness Week, which is from May 4th through 10th this year, I am super excited to be able to work with our expert speaker and longtime friend of FPN's, Dr. Shanna Patterson, to break down misconceptions about neuropathy, whether related to its causes, symptoms, treatments, or overall impact on health, and address common gaps in knowledge. My name is Lindsay Colbert, and I am the Executive Director of the Foundation for Peripheral Neuropathy. On behalf of the organization, its staff, and dedicated board members and volunteers, I thank you for entrusting us with providing valuable educational resources as you navigate your journey living with peripheral neuropathy. Before we begin today's program, I just want to quickly remind everyone of a few logistical items. First, yes, we are recording today's live program and it will be emailed to everyone who registered and also permanently housed on the FPN website along with the accompanying slide deck for future reference. Second, for those who are in attendance live today, we will be carving out time at the end of the presentation for a live Q&A. Please use the questions box in the dashboard of this platform to ask any questions that are general in nature and on topic. We will not be able to answer any personalized medical questions today, rather answer questions that are helpful to the greater audience. And third, we are finally offering closed captioning for those who are in need, and that can be switched on in your dashboard. And now I'm pleased to welcome and introduce our expert today, Dr. Shanna Patterson. Dr. Patterson currently serves as the site chair of the Department of Neurology for Mount Sinai West and Mount Sinai Morningside Operations, as well as the Director for Special Projects and System-Wide Neurology Clinical Operations at Mount Sinai. She is an associate professor in the Department of Neurology at the Icahn School of Medicine at Mount Sinai. Dr. Patterson completed her residency training in neurology and a fellowship in clinical neurophysiology at Columbia University, with a focus on EMG and neuromuscular disorders. She holds subspecialty certifications from the American Board of Electrodiagnostic Medicine and clinical neurophysiology. Her professional affiliations include the American Association of Neuromuscular and Electrodiagnostic Medicine and the American Academy of Neurology. As a dedicated clinician and educator, Dr. Patterson specializes in general outpatient neurology with a focus on peripheral neuromuscular disease and electrodiagnostic testing. Dr. Patterson also serves on the Foundation for Peripheral Neuropathy's board, and I'm thrilled that she's joining us today during Neuropathy Awareness Week to present. And with that, I'm excited to pass the virtual mic over to you, Dr. Patterson. Thank you again for speaking today during Neuropathy Awareness Week.
Thank you so much, Lindsay. It is truly an honor and a pleasure to be here as always, and especially as you mentioned during Neuropathy Awareness Week. It really couldn't be more timely, and it is my pleasure to be able to take some time and think about certain topics as we've put it into the context of myths versus facts. So things, I think there's a lot of information out there about neuropathy, a lot of different sources, and I'm excited to use this venue to help facilitate some discussions about some things that may be of interest, some things that are really timely, and hopefully it'll be useful to the audience. And we're just having a little slide delay here.
Dr. Patterson, try to give the slide one click and then try to advance with your cursor. If that doesn't work, we can do it on the back end.
There we go.
It looks like it works. Awesome.
All right. Great. So I wanted to just start with an overview again of neuropathy. Neuropathy is, of course, one of the most prevalent neurological conditions encountered by physicians of all specialties. The prevalence is actually 2.4% in the general population, and the prevalence increases with age. We see about 8% prevalence in individuals over the age of 55. And now we certainly see, as is the case in the Foundation for Peripheral Neuropathy in today's event, a whole array of different resources, research for individuals with neuropathy. This ranges from professional journals. There are even neuropathy pain and symptom trackers that you can buy online that are kind of a journal format. And of course, here we are with Peripheral Neuropathy Awareness Week, which is a really very, very special designation to be able to focus on this important topic. So this is really where we are now. And I think, what's interesting to think about for myth, so-called myth number one is peripheral neuropathy a modern disease? I mean, we might think with a lot of these journals and the research and the way we think about neuropathy now, it's a very contemporary discussion, something that's very much embedded in modern science and medicine. But is it really a modern disease? How long have we been thinking about neuropathy? And interestingly, when you go back and take a look at it, even before people had a word or a concept of peripheral nerves or the peripheral nervous system, which is the part of our bodies that are impacted by neuropathy, I think that the origins of this concept started with the symptoms, with this nerve pain. Interestingly, the word pain itself actually originates from a Greek word that translates to punishment, which I think is very interesting. Aristotle considered the heart as the origin of pain, which is also interesting. And Galen declared that the brain was the organ involved in pain perception, and transmission was through some invisible nerves. Now, one might imagine, given the era in which Galen was alive, that they would have been invisible, generally speaking, although some of the larger nerves you can certainly see if you're dissecting a cadaver, although I don't know if they were doing that quite then. But already there was this concept of these small nerves. And nerve-originated pain was first described in the medieval period. And as we go further in time, Robert Graves was observing patients in 1828 and pointed out the disease may be resident in the nervous cords themselves. And there, I think we're starting to see some evolution of what we might consider contemporary concepts of peripheral neuropathy, something that we know now it's not always painful, but I think that probably the most salient symptoms that were noticed originally were pain, because it's very hard to ignore, of course. And then also we see an evolution over time of the concept of where is this pain coming from in peripheral neuropathy. And we arrive essentially 200 years ago at clear descriptions that they think there is a painful condition that's coming from these cords, these cord-like structures, which are peripheral nerves. I think I may ask the team to advance the slides on the back end because I keep having a delay, I think, every time I'm doing it. But we will take the next slide. Thank you. Thank you. So we have continuing on looking at some of these historical contexts. I know the font is small, but I think these are some interesting specific medical conditions of peripheral neuropathy. One of the things, that we think about today, like one of the most common causes of neuropathy that we know of today is diabetes on a global scale. And interestingly, you may not know, but that if we go back in time, the most common on a global scale cause of peripheral neuropathy used to be leprosy, which is really interesting. So we see here a description by Freeman called peripheral neuritis, which was published in 1934, describing peripheral neuritis, which we would call now peripheral neuropathy, in such diverse illnesses as leprosy and lead poisoning and something Landry's paralysis, which is the term after a French physician, Dr. Landry, which actually we now refer to more commonly as Guillain-Barré syndrome. So here we're seeing these early descriptions. It's interesting to see, again, about 100 years ago, how very clearly peripheral neuropathy was identified. And certainly things like leprosy and lead poisoning can still cause neuropathy. It's just that as our infectious disease and public health have advanced, these are very uncommon causes of neuropathy. But unfortunately, they have given way to other common contemporary causes of peripheral neuropathy. Also, we have another publication here where it describes the history of peripheral neuritis as a clinical entity. Early descriptions of peripheral neuritis are caused by or associated with alcoholism or deficiency of food were described by John Lettsom in 1787 in London and James Jackson in 1822. So what's interesting is, again, This is something that are hundreds of years ago in some cases descriptions, but they're absolutely correct. And we still sadly see some cases of peripheral neuropathy driven by excessive alcoholism, and also I wouldn't say as much deficiencies of food, because now we have identified that there are specific individual nutrients or vitamins which are deficient that contribute to the neuropathy. But I think in this era, they globally kind of thought of it as a malnutrition or deficiency of food. So we see that though neuropathy is not a contemporary illness only, it is something that we've really had very interesting descriptions of in the medical literature, in the scientific literature, and the philosophic literature, going back for at least centuries, if not, certainly longer in certain ways, that the leading causes of neuropathy are different. The way that we're able to identify causes of neuropathy is certainly more sophisticated, but the clinical condition, when we look back in the literature, is actually very much the same, which is, I think, really interesting to think about. Next slide, please. Myth number 2, peripheral neuropathy is a single disease. So we have all of these journals, scientific endeavors and other things, and a whole awareness week, and it's called peripheral neuropathy as if it is one thing, as if it is a single disease. But in fact, it is not quite true. If we can advance the slide. There are many different underlying types of nerve insults that contribute to different types of peripheral neuropathy that result in different clinical presentations and disease courses. If I were to pick a sort of another illness that I think somewhat resembles this, I would use the example of cancer. Cancer, people sometimes refer to as an umbrella term, but in fact, of course, there are many, many, many different types. Some of them are very, very treatable, and some of them are very difficult to treat. And so I think that, in the same, and the treatments for, of course, for cancer and treatment approaches are extremely diverse, depending on the type of cancer that's involved. So I would say in the same way, neuropathy, although we use one umbrella term, there are a lot of different kinds of causes, a lot of different kinds of clinical manifestations, and even the way that the peripheral nerves are damaged in different kinds of neuropathy varies. And this is important because this is one of the most amazing things about contemporary peripheral neuropathy medicine, is that it is because of this advancement and understanding of this diversity of this condition that has allowed us to be able to look at new treatments and new research into underlying causes. So I think this is very exciting. The peripheral nerve structure itself, there's an image in the middle. There's a cell body, which is sort of the larger, rounder part at the top with the different dendrites coming off of it. It almost looks like an octopus, if you will. Then there is a long projection, and that long projection in the very middle of it, it almost looks like a red thread, is the axon. Those are the core nerve fibers. And around the axon, you can see a lighter kind of almost like a hot dog bun structure that's a paler yellow color. And that is the cushioning, the myelin that surrounds the core axon fibers. It's almost like an electrical wire where you have the fibers in the middle and then some insulating layer over the outside. It is very similar to that. And then, of course, you have the nerve endings, which, depending on the type of nerve, may connect to a muscle or to another nerve. So some types of neuropathy and specifically impact the central nerve fibers or the axons. And in fact, that is the most common cause of neuropathy, or the most type of pathology rather involved in neuropathy if we look at all types of neuropathy. There are other types that specifically really impact the myelin, or the outer coating of the nerve. And those are called demyelinating neuropathies because they take away the myelin, which is really necessary for the nerve transmission to occur. And so we can see that there's different types. In some cases, we think of autoimmune neuropathy, where there may be some autoimmune attack with antibodies or other types of autoimmune pathways involved in attacking the nerve. Sometimes we tend to see those more impacting the myelin. Hereditary neuropathies, which people are born with, or something different about their DNA structure that causes a malfunction in the peripheral nerves. Some of those can affect the axons, Some of those affect more so the myelin. And also sometimes we may see a cause of neuropathy that's more specific to inflammation in the blood vessels, because there are microscopic blood vessels that supply individual nerve fibers. So sometimes we can see patterns where individual nerves are damaged because there's inflammation in the blood vessels that are supplying them with circulation. Next slide. And of course, just to give a couple more examples, diabetes, as we know, causes peripheral neuropathy, but exactly how, that's actually thought to be multifaceted in origin. There's different ways that high blood sugar actually causes inflammation around the nerves. There's different oxidative stress, and it results in degradation of nerve fibers. And there's a lot of interesting science that's been done looking at that. And also chemotherapy. How does chemotherapy cause peripheral neuropathy? Even that is an umbrella term, if you will, because the different types of chemotherapy medications that cause neuropathy do so in different ways depending on how they act. They basically are toxic to different parts of the nerve cell or function. It's shown, we're not going into details, but just to give you an idea, at this small diagram on the left. And so that's, again, something that's highly variable, and that's more of a toxic type of effect in terms of causing peripheral neuropathy. Next slide, please. So we can certainly see there's a number of different mechanisms for causing neuropathy. There's a number of different anatomic elements of the peripheral nerve structure that are potentially impacted in different types of neuropathy. And so we might say, okay, well, we know a few of these causes, but really it doesn't seem like much has happened lately. Everyone keeps saying we need to learn more about neuropathy. We're hoping for a cure for neuropathy or treatment, but it sometimes feels like nothing much has changed in terms of our understanding of, we know about diabetic neuropathy, chemotherapy neuropathy, but what about idiopathic neuropathy, where we know that a certain percentage of patients, no cause is found when you do a lot of the routine blood tests. They're not diabetic. They haven't been treated with chemotherapy. They haven't had any vitamin deficiencies. There's no hereditary cause. What about those cases? Sometimes it feels like we're kind of in a rut. And if we can have the next slide. Depending on the case series, depending on the year, idiopathic diagnosis for peripheral neuropathy impacts between 25 to 46% of cases. I would say usually it is not quite as high as 46%, but certainly I think that in the majority of cases we are able to identify a cause, but nonetheless, even 25%, a quarter of patients, that's quite a few, where if we look at, again, series of publications that were published over the last 10, 20, 30 years, that's the range that we've been looking at, which is still quite high. Next slide, please. So what are we missing? Conceptually, we might think, are we missing something that we just can't test for? Maybe it was a post-viral effect or an environmental toxicity that has come and gone, that there is no way of specifically identifying it. Are we missing something that we just can't test for yet? Is there maybe another antibody that could be contributing, some other hereditary gene that's contributing that we just haven't quite developed the science yet to be able to identify? Or could there be something that's relatively common that is causing neuropathy now, but it just has been challenging to prove on an individual level up until this point? Next slide. And that, I would say, is an interesting opportunity to discuss metabolic syndrome. And their metabolic syndrome is, we'll get into in one moment, is essentially tied in with obesity, especially central obesity or obesity that's results in a larger abdominal girth, as opposed to kind of more distributed obesity over the limbs as well. It is often associated with high cholesterol or more broadly called hyperlipidemia, because it may not just be cholesterol, it could be triglycerides and other types of lipids. And it may or may not be associated with diabetes. But one thing that's interesting is that we have seen, and it has been within the last 15 to 20 years, I would say only, a really clear interest in looking at this independent of diabetes as a driver for peripheral neuropathy. So when we think about the beginning of this dialogue, I would say this article, which was published in 2008, nicely describes it. And interestingly, they sort of flipped the logic. They said idiopathic neuropathy patients are at high risk for metabolic syndrome, which I will say now we kind of think the reverse, which is that patients with metabolic syndrome are at higher risk for peripheral neuropathy. But this is where people started looking at patterns and associations, and they said, there seems to be a link here. Next slide. And again, thinking about what is the definition of metabolic syndrome, if you look at the CDC versus the World Health Organization, the nuances of the definition shifts a little bit year to year, although we do see, and I think they're updating it to try to capture accurately the number of people impacted, but we do see in general patterns of impaired glucose tolerance. So even somebody who may not be diabetic, they may have borderline diabetes, that can be enough, and also have high blood pressure, elevated triglycerides, which is a type of lipid in our blood, a low HDL, which is the quote good cholesterol, so having less good cholesterol. Again, central obesity, which we mentioned, and microalbuminuria, which is basically leaking protein into the urine where it shouldn't be leaking. They found that, again, this central obesity, having more fat cells in the abdominal area, raises level of something called free fatty acids, which is a type of lipid product in our bodies, which can contribute then to inflammation in the body, as well as contribute to insulin resistance, meaning a pathway that puts you at risk for diabetes. Now, unfortunately, we know that in the United States and globally, the prevalence of obesity itself in adults 20 and older and in children as well has been increasing year by year. And here we can see that taken as a whole population in the United States, we are approaching an average of about 40% of the adult population, which meets criteria for obesity. Not everyone who is obese may have metabolic syndrome, but many people will. Next slide. And now as we follow along some of these papers through the subsequent decade between 2008 to 2018 or 2020, we see an evolution of this discourse. Studies are showing a higher risk of neuropathy in the setting of obesity, in the setting of metabolic syndrome, even in patients who do not have diabetes or pre-diabetes. So they've been able to kind of carefully tease this apart because we have felt for so long that diabetes is a clear risk or pre-diabetes is a clear risk for neuropathy. They've looked past that and looked at patients who do not have pre-diabetes or diabetes, but may have obesity and may have elevated lipid levels, elevated triglycerides, low good cholesterol, and they have found an increased risk in those patients for developing peripheral neuropathy. So again, there seems to be some pathway, we presume, in terms of systemic inflammation and other insults that result from that condition that are damaging the nerves. Next slide. And this was a review that was published just in 2020. And a review in the medical literature means that there's enough information about a certain topic to compile essentially a review of that whole question or that whole topic in one paper. And this was Muscle and Nerve is one of the most preeminent medical peripheral neuromuscular journals. And here they published a focused invited review on metabolic syndrome and peripheral neuropathy. So we can see compared to 2008, where they thought maybe neuropathy causes metabolic syndrome, people were just starting to scratch their heads. We've now come by 2020 to the point where we have a pretty robust body of knowledge that supports that there is indeed a pattern that we're seeing between independent of diabetes or pre-diabetes, that metabolic syndrome, this dyslipidemia, central obesity contributes probably through a pathway of increased oxidation and other inflammation to damage to the nerves. Next slide. So I think that's an interesting opportunity because, I think that many patients, it may not be easy, but it offers a lot of interesting treatment opportunities for patients and certainly possible opportunities to turn our attention. And speaking of treatments, I think, again, along those same lines, as we may not feel like much is being done to identify new causes of idiopathic neuropathy, sometimes it feels like there's just no treatments for neuropathy overall. And I think that especially now, we are in an exciting era where new treatments actually are becoming available. And I wanted to share a few of those with you. Next slide. So again, getting back to this concept that we discussed earlier, where neuropathy is an umbrella term and there are many different types of neuropathy or causes for neuropathy. So some of the treatments that I'm going to be describing here are really specific to some of these specific types of neuropathy. Unfortunately, we do not have an umbrella global treatment for every type of neuropathy, but I think that in some ways, it makes sense in the same way we wouldn't expect necessarily to see an umbrella treatment for every single type of cancer because they're so different. We are seeing indeed a lot of traction and a lot of progress on advances for treatment in one subtype of neuropathy at a time. And so I think that it is because that the mechanisms are different, the causes are different. So it makes sense that the treatments that address these different causes would themselves also differ. CIDP stands for chronic, which means it's something that impacts people over time, inflammatory demyelinating polyneuropathy. Basically, what does this mean? It means it's a autoimmune neuropathy. It affects people over long periods of time, and it is actually thought to be an autoimmune attack against the myelin, that outer coating of the nerves. And there have been treatments for this for a number of years. Some of the treatments involve IVIG infusions, other types of infusions. And just in 2024, we have the first new treatment in 30 years that was approved for CIDP. It was the name of the drug is called Vyvgart. That is the brand name. It is actually a neonatal FC receptor blocker. It sort of blocks certain autoimmune antibody pathways and prevents them from contributing to autoimmune disease. This drug has also been in use in other types of autoimmune diseases where there's different antibodies involved, but it was also tested and found to be effective in CIDP patients. So this is very exciting because it is the first time that we've had a new treatment again in 30 years, and this drug also does come in an IV infusion form as well as injectable subcutaneous form. Next slide. And this again just shows a little more information about this. At the left is a depiction of what type of nerve damage is happening in CIDP. So we can see a combination of different autoimmune cells and some antibodies that are attacking the myelin, that outer layer of the nerve. It looks almost like an onion, kind of with different layers peeling apart there. And so what happens is this drug, Vyvgart, and the generic name is efgartigimod, leads to a reduction in some of these circulating autoimmune antibodies and therefore protects the nerves from attack. So it's very exciting, again, to have a new treatment as of last year for this condition, the first new treatment in 30 years. Next slide. Next, I wanted to really pivot to a different type of neuropathy that we, again, have a recent new treatment for. This is a type of hereditary neuropathy called transthyretin neuropathy, abbreviated often as TTR neuropathy. And essentially, in very simple terms, there are different proteins that are produced in the liver, and normally they're processed in the body in a certain way, and everything happens and is totally benign. However, in patients who have a certain mutation, the proteins cannot be processed in a normal way, and they end up forming what are called fibrils, which are these, kind of depicted as almost like this pasta appearing shape over on the side there. And those cannot disintegrate and be metabolized. They essentially start accumulating in different tissues. They actually accumulate sometimes in heart muscle. They can accumulate also in peripheral nerves and lead to neuropathy. Next slide, please. And in 2023, we see some publications here which describe the efficacy of a new treatment, which is called vutrisitan. Yeah, sorry, Vutrisitan, that is actually helpful in modulating the activity of this type of transthyretin uh, condition, and then prevents the accumulation of the fibrils and prevents the fibrils from accumulating on the nerves and in some cases the heart tissue and so forth. And essentially, it's a very effective treatment. This is in a case where we previously had no treatments for this type of neuropathy. So what we are seeing now in the meantime, next slide please, is we're seeing a lot of different types of opportunities for testing for some of these types of neuropathy, simply because people are extra eager to find patients who might benefit from the treatment. I think that previously we offered hereditary testing, but a lot of times it was to kind of help inform patients about their diagnosis or maybe any familial patterns of neuropathy. Now there is an increased push, and some of you may experience this with your providers or may see advertisements for it because we have specific treatments for some of these hereditary neuropathies. And this is another example of a treatment that is not currently available, but is in a late phase clinical trial showing very great promise. And I would, if everything continues along the same line, I would expect that this is probably going to be something that we will be seeing in the next few years coming out as a treatment for a type of hereditary neuropathy, which is a subtype of Charcot-Marie-Tooth, known as sorbitol dehydrogenase deficiency. Interestingly, this type of neuropathy itself was only identified, I believe, in the last 5 years or so, relatively recently. Charcot-Marie-Tooth is an umbrella term for a number of different hereditary neuropathies. Some of them impact the axon, those central nerve fibers. Some of them impact more the myelin. And this mutation was found to be a cause for one of the axonal types of hereditary neuropathy. And they actually identified a treatment that was able to correct for this. So normally the sorbitol dehydrogenase is a type of enzyme that normally helps in processing certain sugars in our system. And when that enzyme is deficient, an abnormal type of sugar accumulates called sorbitol, and that builds up in our body and it becomes toxic. And so what they're finding is that they were able to find this very specific cause for hereditary neuropathy that then served as an effective target for drawing plans to design a treatment. Next slide. And this is govorestat, which is the medication that is in current late phase clinical trials. Again, a phase 3 double-blind placebo-controlled trial called INSPIRE for short. But this is kind of the gold standard level of a clinical trial that we usually see before medication is approved or submitted for approval for treatment. So this is something that has been confirmed to not only work kind of in a lab, if you will, at preventing the accumulation of sorbitol, but also has been tested, and they're already seeing preliminary results that show that patients' conditions also improve. That's what functional improvement means, that the patient's day-to-day functioning, their symptoms, their ability to have improved strength is also improving with treatment, which of course is a requirement in order for it to be released as an effective treatment. So this is really exciting. This has happened in the space of certainly within a decade. I think we'll see discovering the subtype of neuropathy, designing a treatment, testing the treatment, and hopefully having it approved for use. Next slide, please. So again, getting back to one of the points that I was making a minute ago, I think that we are seeing, and you may see, and this is one example of information that you may find either through your doctor, or you might see it on TV, or you might find it on a website, that there is an increased drive to try to make sure that we're finding patients who might have these types of hereditary neuropathy that may not have known about it, because there are more and more treatments that are becoming available. And so this is one example where, again, they're working on identifying people who may have this SORD subtype of Charcot-Marie-Tooth. In this case, they're recruiting people who might be interested in being tested to see if they would be eligible for the clinical trial because it is not fully FDA approved yet. But again, I think that, this is exciting. This is an exciting time. And I think that in the coming years, we'll be seeing some more treatments available. Next slide. And lastly, this is the most early phase layer of investigation, I would say. But if there is any success in this line of inquiry, it would have really robust, widespread impact. The concept going back to, again, pre-diabetes, metabolic syndrome, diabetic neuropathy, which, as we know, is our biggest cause of, leading cause of neuropathy. The best that we have so far in many cases is to encourage patients to manage the diabetes, to prevent diabetes, to exercise, to manage their weight. And sometimes it's easy, sometimes it's very hard. But we are starting to see investigation with the glucagon-like peptide 1 receptor agonists, or GLP-1 agonists, which are these new class of drugs that you may have seen advertised on television that are approved for patients who have type 2 diabetes, and some of them are also being prescribed to treat obesity. So some of these drugs, for example, you may be familiar with names like Ozempic or Mounjaro. These are those medications. So some people are looking at them and also saying, could these medications help diabetic peripheral neuropathy? We also think, in some cases, if they help metabolic syndrome, that may also be of benefit. So people are looking at this question, and this is, I would say, early. This is a publication from 2024, and they are just starting to look to see, do some of the structural changes in the nerves of patients with neuropathy improve or respond to treatment with these drugs. So this is very, very early. And I will say that though the article that I'm displaying here shows that there is a reversal of some of the pathology at the cellular level, that there is also in this field some conflicting evidence depending on the study. But I do think that there are many people who are looking at it, so it will be something very interesting to keep our eyes on over the coming decade. And clearly, a breakthrough in this area would be very meaningful because this is the most common, probably, cause of neuropathy in our country right now, and probably globally for that matter. Next slide. And I wanted to also talk about, I think, was there a slide before this? We may have skipped. Myth number 5. Oh, maybe not. Okay, well, myth number 5 is actually that there is nothing that I can do to help myself or to help the situation with respect to neuropathy. That is myth number 5. And that is not true. The idea being that advocacy is something that is real, advocacy is something that is very effective. And I would say that, especially as an individual patient, advocacy starts with you, and advocacy can start for you, being self-advocacy, or if you have a family member with neuropathy, helping to advocate for them. This was, interestingly, a topic that was featured very broadly at the American Academy of Neurology meeting this spring in San Diego. They talked about advocacy at all levels. And I think that, when you're thinking about yourself as a patient, or if you have a loved one who you're helping with or care, advocating for them, you could be advocating with their healthcare team, with different patient support groups, physical therapists, pharmacists, different things. They put up these key steps that you can use in any context, and you might focus on different steps depending on who you're speaking with. But these are steps that were suggested as effective ways to advocate. So first, of course, developing a rapport, introducing yourself, forming a relationship with the person, telling your story. What's your experience with neuropathy? What's happening? And then make the ask. What are your priorities? What are you asking? If you're going for a doctor's appointment, you can advocate for yourself. Take a moment to reflect. Think about, what are your priorities right now with respect to neuropathy? Is it treatment for pain? Is it mobility? Is it preventing falls? Is it all of these things? Looking for information about clinical trials. And then after you make the ask, think about in tandem, like, what are some goals that you might have or that you might want to communicate about your priorities? Is your goal to find improved treatment for pain and you'd like to circle back, to make sure that you're trying to meet that target in the next month? Or is your goal to have better mobility and to find a pathway so that you can walk more independently in the next 6 months or a year? So setting some timelines can also help, and communicating those timelines, because that helps, again, advocate and draw forward a cadence for future appointments, for future dialogues, to keep things on track for follow-up. So I think that these are some steps that anybody can use for yourself or for family members in advocating to improve the care for neuropathy. Next slide.
Oh, there it is.
Oh, there it is. All right, next slide. And I would say at a larger, more global level, advocacy starts with us. So we are so grateful for the Foundation for Peripheral Neuropathy and all of their work. They're doing an incredible amount of advocacy, and a lot of other organizations are as well. I think, all the time, but maybe perhaps even more specifically during these years, advocacy in terms of public policy, supporting resources for neuropathy research, which we have seen in this talk has been so critical to coming up with improvements. And so again, I think that you can certainly become involved if you wish in that type of advocacy as well. And in fact, I just wanted to point out that the Foundation for Peripheral Neuropathy actually has on their website some information that you can find here. This is just a screenshot of it, how to take action for more research for peripheral neuropathy. And there is actually a link. This is, of course, just a picture of the letter, but you can find actually who your senator is, find their emails and their contact information, and send them a message to encourage them to support funding for peripheral neuropathy. And actually, interestingly, from a legislative perspective, from a congressional perspective, some of this funding is linked with the Department of Defense peer-reviewed medical research program, or PRMRP, which sounds confusing, but that's just kind of where it lives. And so very specifically, when we're asking for support, that is the way we ask for support. That is the very specific thing that we ask our representatives to support during the fiscal year 2026. So this is something, again, if you're interested in making a difference, you can make a difference. You can make a difference in your own care, in your family member, your loved one's care. And frankly, I think, we can certainly, and we are making a difference, even driving together the whole field in finding better treatments and support for neuropathy. Thank you so much, for everyone. And there are certainly, I think, many more myths that we could unfold, but hopefully those were some helpful tour, looking at everything from history to where we are now, how far we actually are coming, even though it may feel like we're not, and also how we can all make a difference, both on the individual level and together. Thank you.
Thank you, Dr. Patterson. It was a very thorough presentation, so I really appreciate that. I think in just the last 45 minutes, we kind of touched on a lot of things, touching on awareness, advocacy, research, and obviously education. And that really are the main pillars of what our organization works on. So, so thank you again.
My pleasure.
So we're going to go to the Q&A right now. We have about 15 minutes left or so in the program. And I kind of want to talk about from pretty much start to finish when a patient gets diagnosed, or maybe they don't have that diagnosis yet. As you know, peripheral neuropathy is extremely challenging to diagnose. There's a lot of healthcare professionals out there that don't really understand the nuances of this specialty. What do you say to a patient who either is newly diagnosed or hasn't yet been diagnosed to ask their doctors about what kind of tests that they should be asking or taking or doing to get that diagnosis that they need to move towards their path to recovery?
So I think it's a great question, and I think that there's a few different pieces. One I would say is Um, for patients who are having significant symptoms with an impact on their daily life, whether it's mobility, pain, or something else, I think that it's important to be able to get more care, or to be sure that you've really kind of left no stone unturned, so to speak. And I would say that certainly even primary care doctors, most of them are well versed in saying, okay, are you looking for diabetes, maybe looking for vitamin B12 deficiency, and a few other things. And if you then, by extension, have access to even a general neurologist, they're usually able to coordinate some other testing and looking for things. But for some patients, they do receive feedback that, well, that's kind of it, that's, or everything was normal, or, would you like just some medication for pain? And that's kind of the end of it. And clearly that's, we have so much more, as we can see here, to offer potentially. If there is a situation where you feel like your condition again is really impacting your daily life, I would encourage you, if you can, to seek out care with a neuropathy specialist. In some cases, that may mean making a trip and doing some research. And we certainly do see patients who do that across the country. And it may be that you have a local doctor that is going to kind of be somebody who you see more regularly for care, but that it may be worthwhile to get some specialized testing and evaluation to make a trip, whether it's once or maybe once a year, or maybe a couple times and then once a year, to somebody who's a specialist in peripheral neuropathy. And I know that the website, the FPN website, has a number of those providers listed. And in general, I think if you go online to different, they may not always be in certain private practices, but usually if you look at different academic centers with medical schools with different subdivisions, you may see like a neuromuscular subdivision, and that's where the neuropathy specialists usually are. And you can read about the doctors online to vet them if they're not somebody who's already listed on the foundation's website. But we certainly see that patients are coming, and sometimes it's, again, like maybe a one-time visit, and then to provide more information perhaps back to their local doctor. It can be very helpful. And I would say that in some cases, providers also offer video visits. So we do see some patients who may come for that initial consultation, get tested, be examined, which is so important for neuropathy. But then you're able to really do more than you might imagine for doctors who can then facilitate follow-up visits through video visits to review test results, adjust different treatments, and so forth. And that's something that we've seen with telehealth kind of since the pandemic, that's become much more broadly available, and hopefully it will continue to be so. But it is a helpful tool to keep in mind, especially if you're coming from far away seeing specialists.
Great, thank you so much. Now, after someone gets their diagnosis or sees the specialist to get their tests run, and they have a better understanding of the cause of their neuropathy, it might actually be an unknown cause known as idiopathic, but now they know, right, what they're dealing with, and now they're trying to manage their symptoms. So this is what the next question is going to kind of lead into, in that, many patients are struggling with only medications being prescribed to them. And now here at the foundation, we try to encourage a holistic lifestyle approach of diet, exercise, and incorporating other types of treatments in there, inclusive of acupuncture or physical therapy or other things like that. Now, I'm curious though, Dr. Patterson, how do you talk to a patient that is getting frustrated, not getting their symptoms appropriately controlled? Maybe they want to avoid medications. Where do you tell someone to kind of start so that they get to the path that makes them, be able to live the life that they're interested in living?
Sure. So I think that first of all, it's really a partnership, this relationship, this provider, physician, patient partnership. And so as you mentioned, what each patient wants or feels comfortable with is different. And part of that dialogue is figuring out, where are you coming from? What's important to you? What are sometimes even people who are open to everything, maybe taking other medications where they can't take, some of the nerve pain medications. So we have a whole armament of different options. So one, I would say, is, and it can be a trial and error process, not one size fits all, of course. So for some people, they may notice just keeping their feet warm helps to keep them comfortable, and wearing certain types of shoes, or using a certain type of blanket at night, can be helpful. So it's, again, experimenting with different things, putting different ideas out there. For some patients, like you had mentioned, physical therapy, massage can be beneficial, acupuncture can be beneficial. For some patients, we found that if they are not as able to, or they don't want to take oral medications, which is very understandable, that there are actually a number of topical treatments that can be beneficial, different types of creams. Some of them have more natural ingredients. Some of them are actually compounded versions of some of the oral medications that absorb through the skin. Some of them are patches that deliver medication through the skin, and those can have very local effects without having a systemic medication effect that you are swallowing. So for some people, we try that as well. And of course, then there are different oral medications for patients who have really intractable, horrible pain. And this is very, very rare. They do also have implanted nervous system stimulators, which are it's a surgical procedure which delivers electrical impulses to the nervous system in a way that it kind of interferes with pain and helps people feel more comfortable that way. But for some patients, it helps them really reduce the amount of medication that they're taking, which is important and brings them significant relief. So there is a huge, huge array. The one thing I always caution people about is if somebody is trying to sell you something, because there's a lot of different things out there, if someone is trying to sell you something promising it's going to cure your neuropathy or cure your symptoms, and they want to charge you a lot of money for it, and it's not covered by your insurance, I would ask your doctor about it first, because unfortunately there are a number of things out there you really don't need to spend money on, and we don't have an all-about cure. So if somebody is claiming to say, oh, this will cure you or totally eliminate your symptoms, they're probably also not being totally truthful.
Yes, we actually cover a lot of that in some of our newsletters and other communications to try to highlight what to be on the lookout for. So we agree that that is a challenge, and it's really hard to know what is true and what is false, and kind of congruent to this presentation, what is myth and what is fact. Neuropathies are a very complex condition, so we're appreciating that even more so as we learn more. So the next question is, you really highlighted fantastically a lot of fantastic new research that's out there, new treatment options for specific types of neuropathies. Curious what some of the other causes of neuropathies, what those patients might be able to look forward to in the next 5 to 10 years, whether it's chemo-induced neuropathies or other types of hereditary or genetic neuropathies that, are very common right now, and folks are just kind of grasping at straws, wondering if in their lifetime they're going to see some more advancements. Could you speak a little bit maybe to some of those others that we didn't cover in today's presentation?
Sure. Well, I think that for the chemotherapy neuropathies, I think that probably the biggest driver of change for that will be new chemotherapy medications or new cancer treatments that are not as likely to cause neuropathy, because I think that the toxic effects from some of the types of chemotherapy that we've mentioned, in the slide, it's hard to effectively treat or prevent those types of toxic effects. So I think that but certainly there's a lot of awareness about it, and you will see for patients who are undergoing chemotherapy currently that sometimes their oncologist may be sensitive to those symptoms and adjust their treatment in response to those symptoms, or look at other baseline risk factors for neuropathy going into chemotherapy. But I do think for that area that a lot of the newer cancer treatments, which oftentimes have different mechanisms, may be less likely to cause neuropathy because they don't have the same kind of broad toxic effect that some of the older chemotherapy drugs did. I think that a couple of very exciting areas that we're seeing now that are rapidly evolving have to do with anything that has an immune system component. We're seeing so much drive now with different types of immune system drugs, not just in neuropathy, not just in neurology, but across the board. And I think that we're likely to see that continue. I think that also We're seeing a lot of headway in terms of understanding of hereditary or genetic causes for neuropathy and other illnesses, and we're seeing a lot of new treatments that are targeted at that. So I think that is likely also to continue beyond the scope that I discussed today. And I think that kind of the holy grail, as we ended with, that I think we're just beginning on, because people are starting to see this as a problem and starting to scratch the surface in terms of really robust investigation, is this concept of how harmful systemic inflammation is, and that can be linked with obesity and lipid abnormalities and so forth. We're really just starting to see that line of inquiry even over the last decade, and I think that we're starting to see a lot of investigation and when it is recognized that that is not just a cause of neuropathy, but a lot of different illnesses. So there's a lot of skin in the game, if you will, from a medical and scientific community perspective. But I think that we'll see, I don't know if we'll have a treatment. It would be great if we did, and maybe we will, but I think we will see a lot of new science coming out about that over the coming decade.
And then the last question that I wanted to ask, and I am apologizing to everyone else's amazing questions that we didn't have time to answer today, but you know, obviously folks are on a lot of different medications, right? And whether it's for their primary cause of neuropathy or a different type of condition that they're also battling, what do you think about, right? Like, I'm trying to figure out how to ask this appropriately, because there's some medications that can cause neuropathy, but you need to take them because maybe you have a deficiency in some type of vitamin, maybe you're dealing with something else that is equal or far greater than the neuropathy that you're incurring, but just the pure fact that you're taking that medication is actually worsening potentially your neuropathy and or causing it to begin with. So how do you navigate that space when there are various toxins or other medications that folks are taking, inclusive of chemotherapy drugs, that does cause the neuropathy? How do you balance that out, knowing that you might be kind of hurting yourself more in neuropathy, but helping yourself in a different facet? Does that make sense?
No, yeah. Totally makes sense. That was very well articulated, super clear. So I think it is a dialogue. It is a communication between doctors and their patient, and it is very individualized. And I will say, you know, in cases of a lot of chemotherapy, if that's really the only best treatment and it will save your life, we link arms and we go forward together and we monitor and we treat. We maybe make adjustments. But I would never want a patient to not take their chemotherapy that could save their life because of neuropathy. We will manage the symptoms. We will get through it if that's what it takes. For somebody who, it's interesting, even the statin dialogue, because we talked about, it used to be thought that statins were a big contributor to neuropathy. Now we don't think that as much anymore. But we wonder in retrospect if maybe it was always the metabolic syndrome with the hyperlipidemia, and those patients, a lot of them were on the statins. So it's interesting, but I've had certain dialogues with doctors about statins over the decades, and we've said the patients are worried because they've heard about statins being an issue. And we say, look, actually now we know that they're not that much of an issue, but you really need this to prevent a heart attack and other things. So we work it out. We take it on an individual case-by-case basis. Usually, I think that everyone, after we have these discussions, feels comfortable. Sometimes if there's a medication that's not essential or critical to continue on, or there's alternatives, we'll talk with the other doctors together and say, let's take a holiday from this drug for 4 months or 6 months and see, does your neuropathy significantly improve or not? And just kind of doing that test to see if something changes or not can also be helpful, because maybe that wasn't really the cause for that particular patient. So again, it's communication and a team approach, but I would say we have a lot of success in those cases also, really kind of bringing everyone together and finding some common ground and common goals.
Great. Well, thank you so much, Dr. Patterson. I really appreciate your expertise today. And thank you to everyone joining us, and happy Neuropathy Awareness Week. We hope everyone found the information today valuable. We hope that you will continue checking our emails and our website for opportunities to participate in our advocacy efforts, or our research efforts, and obviously our educational efforts. So thank you again. keep us posted with how we can continue supporting you. You know where to find us. And again, thank you so very much, Dr. Patterson, for today. We
Thank
really
you.
appreciate it.
Thank you. Happy Neuropathy Awareness Week, everyone. Thank you.
All right. Bye, everyone. Thank you.
Goodbye.